Wow, it is good to be back with you. It's also, I'm from Idaho, in case you all don't know that. A lot of you know me, and I've had the privilege to be here multiple times. So I always find it a privilege to be part of the HFMA family anywhere in the country. It is interesting to watch how we've evolved the last couple years. I am a big believer in continuing to do the remote education. If we're about education, then we should continue to reach out to all the people who can't come. You know, we all know our budgets are tight for travel, and so I really appreciate that. So I also got to do a whole lot of this. Let me see if I can make the thing work. You want it? That. How many of you said, this is what, are you on mute? You're still on mute. I swear to the Lord, after 2.5 years, I still get told I'm on mute. And I'm like, seriously, I can't do this yet? I think we need to have a little fun with ourselves and forgive ourselves for the silly things that we do sometimes. I also think it's important that we continue to support each other through this. There are some slides I want to cover with you that are a little humorous, but there's also a lot in here that I'm going to cover fairly rapidly because this is a good 2-hour class. So I'm going to move it so we can make sure we get it taught in the slide I have. I always love to put in, what does disruption look like to CFOs? What keeps you up at night, CFOs? I think there's 3 C's. Cash flow, customer service, and crap. How about the third one? I'm all about that third one. You know, there are times when I work with CFOs and I have to say, get your checkbook out. This isn't a funny time, haha. And the next time I'll say, hey, you get a deposit slip for that. And so lots of fun things because we have a very difficult job. So when I use a little words, because I'm trying to teach it in different ways. But the bottom message, which I love the thing for this session, was success. Let me see what I wrote. Setting trends for success. But as you heard, my family formed a Patient Financial Navigator Foundation in 2017 as part of my personal mission to pay it forward. And so a lot of what I do still is try to do community outreach. Even the worst of COVID, I had to shut down. But I write a regional newspaper, you can all do this, called Healthcare Buzz. And it's all on my website. Go get it, put your name on it, and say it's yours. I don't care. I don't believe in any copyright stuff because I think it's all about education. But in this particular topic, I think we are going to hear me reference multiple times, be the patient. When we talk about HFMA, I love to hear Joe Pfeiffer talk about be where the patient is. I love all that nonsense stuff. And it's nonsense to me when you forgot to be the patient. Well, if nobody cares about transparency, have you asked the patients? How about knowing what the no surprise bill is to be out of network? Have you asked the patients? When you think you have a great collection policy, did you ask them about your payment plans? I've done it for 45 years. And one of the things that I still do is be the patient. Unfortunately for my family, my mother-in-law died yesterday morning after I was already on the plane. So here's where I am. But the irony, a little irony for me, is how we made it happen. My mother-in-law died very rapidly. And so I was gone. I drove 9.5 hours to be back with her and my husband and their family. And then we started realizing we were going to have to do hospice. There was no recovery for her, which totally unknown how this all happened so fast. So I helped in our role as the family advocate, because you all are, how to help them facilitate through the business of healthcare. Y'all know you're a business, right? We are the business of healthcare. Things like only 2 people could be in the room and it had to be the same 2 people for the entire day. Anybody think that's about as ridiculous as you can get? I'm fighting with the hospital going, this is ludicrous. There are a lot of us that want to see her. No, same 2 people. So finally, when she was declared terminal, there was no help for her. The physician stepped in, because I went to him. I said, you have got to change this. I've already called the hospital and made sure they all knew how unhappy I am. They could care less. But the fact of the matter is the physician stepped in and said, anybody can come and see her. So we had 14 people in the room with the trusty little armbands. And when they would come in, we'd all just hold our armband up. This is called the protest, just so y'all know what that was. But the truth of the matter is, nobody knew how to maneuver all this junk that was going on with my mother-in-law. So unfortunately, as much as it's hard for all of us, I stepped in and I coordinated hospice for her. So I've been doing hospice with her and our family for the last 5 days. When it became, she was slipped into a coma 3 days ago, it became obvious she was going to pass, but we just kept waiting for me to leave or not leave. And it was really the attesting of a family who supports each other, who voted yesterday morning for me to get on a plane. I'm going home tomorrow morning, but this is why I love our profession. I love the fact I could help my family. I know hospice. I started it 20 years ago and ran it for 10 years. I know how it works. I know the difference between home health and hospice. I know she's in a Medicare Advantage plan, not traditional Medicare. I knew to call and try to talk about what would happen for the right placement. Where should she go for the right hospice? Whose family knew how to do that? And nobody at the hospital stepped in. I'm begging for a discharge planner to reach out to me. Begging. 2 days later, I finally got less. Yeah, I bet, how many of you bet I get less than happy when somebody doesn't do what they should do? You know, we all talk the talk. We all talk the synergy, everybody do, and then like, could y'all do that then, please? So I am very blessed to have been with this family, my husband's family, for the last 5 days. I'll be going home in the morning. So I am here because they said this is where I should go. But I was on the plane when she passed. I think this was sneaky on her part. Because I had a flight I caught, and she passed away 20 minutes after I was in the air. So there was no turning back, sort of. So if you know anything about rural airports, getting in and out of Idaho is just driving it. You might as well drive it. It's faster than getting in and out of Idaho. So everything I talked to you about today is going to have a lot, you heard in the write-up, it's all about be the patient. And the payers are going crazy, but the fact is, you send a bill to the patient when a claim is denied. I just got one. My mother-in-law had an open heart, the same mother-in-law, had open heart surgery in December at the University of Utah, out of network for her. We got approval, prior authorization. I did a ton of work to try to convince them no other physician would touch her. This was the only one that would. So they approved the surgery, and now her plan is denied every single follow-up visit. Every one of them for being out of network. And the hospital sent me a bill to pay the entire thing. How many of you think I am impressed with Be the Patient? What 80-year-old person knows what to do when they get that bill? And so when we talk about the business of healthcare, the payers make us crazy. I get it. But what's our job? To navigate for our patient. Nobody's navigating for my father-in-law. He got the bill and he about had a heart attack. And I've been in power, I've got the proxy. So I look at the EOBs against the bill and I try to fair warn him, don't open that bill from the university, don't open it. Of course he opens it. And the next thing I did is, oh my God, I owe all this money. And I'm like, John, it doesn't work this way. Don't open the bill. Shame on them for sending the bill. Shame on them for not calling to say, what the frick are you doing, insurance? This is a follow-up to an approved open heart surgery. Instead, my father-in-law gets all these bills. Is that okay with you? It's not okay with me. That's the business of healthcare. It's not what we're in the business of, is putting your arms around your patients. You know they don't pay you because of credit policy. Y'all figured that out? They pay you because you put your arms around them. They paid you because they care. And I can guarantee you the advice I give to people in our Patient Financial Navigator Foundation, all the consulting we do for no cost to these families, is get the bill, hold them accountable that they explain it to you. Patient-friendly billing was not for us. It's for those patients who don't understand what you sent them. So I think we have so many opportunities to look great with our public. Man, oh man, what we have survived the last couple years. So opportunity, when we talk about the payer, you can never forget the patient. It always floats back to them. So let's talk about this one. This was came in HFM, the recent article, about what patient, did you see this stat? Did it make you alarmed? 95% of all Americans find the perceived value of healthcare is inconsistent with what they paid for it. Inconsistent, your bills, they don't think have value because the bill is so high and the care they received, they do not think it warrants the bill. 95% said that. And I love the article when it says, hey, boards, pay attention. Your public doesn't support you because you maybe haven't been a navigator, maybe you haven't been the advocate that you say you are, and I'm not talking about the social worker advocate, I'm talking about the rev cycle advocate. Our job is to get them to understand their bill so they want to pay it. As long as they're frustrated with us, don't expect them to pay it. Because by the way, you know, there's nothing to repossess. You all clear on that? I used to teach my employees this, the 80 employees I had for all those years. You're in the business of unsecured loans. What? Patients walk in, they get Cadillac care, and they walk out. What are you going to do, repossess the gallbladder? I want that baby back. Give me that baby. You realize that's the business you're in. So you've got your hands full trying to get them to want to pay you. So please stop treating them like business of healthcare and start treating them as a person who's scared, upset, didn't expect to have the illness, didn't expect to have their life disrupted, and they need help to understand it. I love the 7 strategies that was part of the HFM. This is a series, and this is the one I like the best. 7 strategies that we need to be doing to change the perception of the bill that you're sending has value to the patient. Because they're saying it doesn't. The care they're receiving does not equal the bill they're getting. We can all talk about it, but that's what the patients perceive. I love the 7. Look at what the last one is. Start yesterday. Love that one. I would have added number 8, be the patient. That's how we change the way our patients perceive us. In the rev cycle, our job is to advocate for the patient to get the bill paid correctly, not just to collect a bill. If you start thinking about why does a patient come to you, it isn't because they chose to. They didn't ask to come to your hospital. They didn't ask to have their life disrupted. They didn't ask to have this monster bill. They didn't ask to have their insurance pay so little. Now what are you doing about it? That's the message, and I hope you all read those series, because that's a very good article. It kind of caught my attention for sure. Let me see if I can get this thing. So we're talking about some big issues. Tim asked me to look at a couple things for you. So the first thing I want you to know is that the rural emergency hospital did pass. So some of you that are critical access, that are rural, very rural, and you have a census, some of you are even frontier hospitals. Montana has a bunch of those, which is lower than a CAW, critical access. So we have now a way for you to get better reimbursement as an emergency rural hospital. It's very interesting. That did get approved. The second one I was asked to look into was split billing. It's been postponed now, but what they're proposing is that for your hospital-based clinic visits, when you have a physician and a mid-level, that they're going to add up who had the most time, and whether it was the mid-level who had the most time, they only give 85% of the fee schedule. So that would mean that they're forecasting a drop in the physician payment from the payers, because if they go with this new methodology, whoever has the most time. How many of you think the mid-level has more time than the MD? You ever been to one? Mid-levels come in, do the whole workup, and the doctor rushes in. I'm here about, okay. If that's the case, you're going to see a big drop, because mid-levels will always spend more time with they do than the MD does. So this is a fairly significant issue. It is delayed, but they're also asking the docs to maybe look at the complexity of the E&M and time, not just time. So any of you that employ physicians and mid-levels, you might want to pay attention to this. It's delayed, which doesn't mean it won't happen. The next thing is long COVID. The reason this is so important to you is because patients have new medical bills. How many of us have it? 24 million are suffering from long COVID. 1 in 4 have symptoms beyond the 2 weeks. I hope you're following this. These are new medical bills for patients, and there are many significant medical bills. The other thing they're finding that of 4 million can't go to work. Now they were healthy as can be before they contracted COVID, one of the variants. Now they can't go back to work. Now what's their insurance look like? Now what does their bill look like that has to be paid? Are y'all paying attention? Those of us with long COVID, and yes, I do have long COVID. This has been a journey for me, and something I have mixed emotions some days about what I feel about people who have comments about this, which I wish sometimes they would get it and they would appreciate. I've never been sick a day in my life. If I had strep, it was rare. That was it. That's all I've ever had. Immunized, I believe in science. I believe in all of it, because that's a gift for me. So I went to the Western Symposium last year. And we were all supposed to be masked up, and we were supposed to be vaccinated or proof, and I got very, very sick while I was there. So I exposed the whole frickin' place, which made me feel really bad. I wear a mask all the time. So I wear masks on airplanes, me and about 2 other people. But I can't afford to get sick again. I came home on January 19th. I am now in month 10 of my long COVID. For me, it was a journey that had a lot to do with a very unusual. Mine is nerve and pain up the back of my skull that debilitates me. So I have a medication regimen now. I feel like a walking pharmacy, but at least it's working. My blood pressure was 160 over 120 when they admitted me to the hospital for a stroke. They thought I had a stroke. I should have, but I didn't because my long COVID was doing it. This is a massive hit. I cough all the time, but it's a bronchial cough now, because I have adverse reactions to the steroids they gave me. I had to go in concussion protocol. I've had adverse reactions to 2 sets of meds. Obviously, I can't take drugs. It's obvious I'm not a drug seeker because I can't take any of them. What have we learned? I had to learn to listen to my body when it shuts me down. How many of you think that's easy for people like me? Yeah, my daughters call daily. Are you resting, Mother? Sure. How many hours you work today? Only 10. Yeah, okay, you're done. You need to, we need you to rest. The thing you need to appreciate about the long COVID patients is they will have bills. And I have to tell you, I have monster bills now. From 2 different visits to the ER, both of them were to rule out strokes because my body started reacting. Now, the interesting part for me, for any of you that are interested in some of how very different this is, in May, I started having morning sickness. That's a little funny for the women. If you look at my age, that isn't quite possible, but my husband would cook and I would smell the food and run in and throw up. So we had gastro that was happening. I've had to breathe different. I go to respiratory therapy. I can't breathe through my shoulders anymore. I have to breathe through my diaphragm. We can't move my shoulders. We have to try to teach them to stop firing the nerves. So I'm on drugs that I don't even know the names anymore. And it's only a little funny because it becomes, what's the next thing that's happened? The good news is the drugs work. Bad news is I still have everything I've ever had. So it's been an interesting journey for me personally. I have so much empathy for chronic pain. Oh my Lord. We need to learn how to have more empathy for these, quote, drug seekers. I could easily be one to try to get through my days. So when you think about the long COVID, why does that matter most to you? You've got bills. I have new bills. And do you know that long COVID is considered a disability now with Social Security Administration? But there's no way to diagnose this, so nobody's getting it. Which test could you give me to test my long COVID? There isn't one. So lots of issues. Please pay attention. President Biden has put together a group now to study long COVID. When it comes to Idaho, I'm signed up because my case is rather unusual with the many different symptoms I'm having. So it's very interesting. When you have somebody with COVID, please, they need your compassion and they need your understanding. We don't like the way we're living right now, and I have to believe it will get better. So when we talk about, there was one more thing, I'm going to move to this one. Let's talk about other big picture issues. The Inflation Reduction Act was a big win for your patients and the insulin. Now that was a big win for us. We have to be sure our patients understand that. The Medicare Advantage plans have always been able to negotiate drugs. Medicare Traditional has not. So with the Inflation Reduction Act, the President Biden and the Congress approved it to have a $35 cap on insulin. But unfortunately, the Republicans in the Senate denied the ability to have a $35 limit for commercial, just for Medicare patients. So I hope one day we'll move quickly to have a $35 limit for anybody who has diabetes. The senior access, this is a lot of movement right now on the national level about Medicare Advantage. You talk about payers gone wild. Medicare Advantage plans, we've got to do such a better job. Now, I have a lot of classes on my website that you're welcome to go get. You're going to hear me talk about them. Go get them. They're yours to use however you want to. Sometimes they're not as updated as the one I'm teaching, so you may want to ask me and I'll just send them to you. The senior access, this is one about Medicare Advantage and all about prior authorizations. I have to tell you, one of the funniest things I love when I read about how we're fixing prior authorizations is we're going to stop faxing and make everybody send them electronic. Anybody think that fixes the problem of prior authorizations? I think I lost you. Am I still on? Okay. One of the things that I find just a little comical is because I heard a speaker a year ago talking about, we've been faxing for 30 years. We need to fix the problem and go electronic. And I went, how did that fix the problem of not knowing when a prior auth is required, not knowing what the payer rules are behind the prior auth, not knowing how we get past the prior auth denials, but by God, we're going to put it in a portal. That fixes it. That fixes the problem. So, by goodness, sorry, I didn't say that, did I? By goodness. So one of the things, that's a little humor, one of the things that you'll find is they're trying to really force automation with the payers. But the biggest thing is they're trying to figure out why you have so many. Some of the biggest problems we think prior authorization is what? Patients get cancer care. I have this patient right now contacted me and asked for help. They had cancer care, their drugs were approved, suddenly the payer stopped approving drugs. Why? So the family is devastated. They're trying to figure out how they're supposed to pay for the drugs. Shame on the hospital. None of you thought you should call the patient and help them understand how to fight this prior authorization denial? You think the little cancer family knows how? They called and asked, they're begging for help. First thing I do is get authorization, I call the payer and I say, what did you do? Why did you deny it? Well, it's experimental. Not hardly, here's the proof it's not, but you approved it for the 2 previous treatments, why'd you suddenly just stop paying for it? What patient knows how to talk like that? We have to be their advocates. You don't just send them a bill. That isn't the way and our patients, why do they think that 95% don't believe there's value for our bills? Because they don't even understand them. And then when they need help, you send them to your portal. Anybody think that's insulting? Well, that's what happened to me. I asked for help to understand this, they sent me to the portal. I said, if I could understand the portal, I'd understand what I'm supposed to ask you. I said, I don't get to talk to anybody. Well, we just use the portal for these things. That is massively insulting. But the real problem is we're trying to consolidate and automate, which is such a good thing, but we forgot humans get scared with their medical bills. So we have to help them. And we also have to hold the payer accountable. That family was trying to find a way to pay the drugs. They were trying to find a way because all they had was the insurance denial. Not medically necessary, which I hate that phrase. Not medically necessary, and the little old families left trying to figure out what? Those are where we step in. Rev cycle leaders, that's us. We step in and we'll say, let us fight that fight for you. There's no reason that should have happened. But the bills are over here and statements go out and and the care is over here and the two shall never talk in some settings. The other thing that's happening with COVID is the public health emergency is here. Boy, do you need to pay attention when it stops. We have gotten a little comfortable with this. The public health emergency has 72 waivers that you're getting to take advantage of right now. The biggest one for you to pay attention to is no Medicaid patient has been taken off the rolls since COVID started. Medicaid is now the biggest payer in the country. When they start evaluating patients, you will see a huge drop in your Medicaid money, and many, many of these patients will become self-pay. So you need to get ready to look at trying to get them hooked up on the exchanges, because remember they get compensation if their income is lower income. But have you read what the whole states are saying? Like Idaho said, oh, we have about 2 people to do a couple thousand people. We better get some funding, Idaho congressman, to cover all the other. We need at least 6 to 10 people to start doing all the evals to see how many of our Medicaid patients need off the rolls. There will be plenty. They have not, remember it's resource-based, so they have not moved anybody off the state of Washington. None of your Medicaid patients were pushed off. They used to be on 1 month, off the next, on one. They're all been on for 2 years. So that is a huge hit. When the public health emergency ends, you'll get a 60-day notice. Right now it's through January. They're saying that they're going to lift it, so you'll get 2 months notice. It's going to happen. You better be in touch with the Department of Health and Welfare. How are you going to handle all these Medicaids? There's more out there that we have to worry about with the SNFs and the swing beds and all of that, but this is the big one because the states are not at all ready to handle this load. And it may be reactionary, it may be very well done, we're just not really sure. Another thing I would challenge you to do, and I've added it to this slide, is the DRG payment. One of the worst things that we heard, and we probably still would if we were still in the worst of it, is that, hey, you got a 20% add-on for a diagnosis of COVID to your DRG. How many of you have taught in public what a DRG is? In my Patient Financial Navigator Foundation webpage, you have all the classes I teach to all the communities. And the one I teach is Medicare 101, and then I teach how does a hospital get paid. I write articles about that all the time. No other business creates a charge for $5,000 for an outpatient procedure, gets paid $1,000 and writes off the other $4,000. Welcome to healthcare. When I taught how DRG's paid at one of our boot camps, we have about 200 people that usually come, and again, it's community, however we can help them, and I put together lots of speakers, and it's really very cool. I will look forward to start doing it again one day soon. And I teach the Medicare 101, and I teach this is how hospitals get paid, and I teach a DRG. My father-in-law got his open heart surgery bill from the university at $310,000. And I said, don't open it, John, don't open that bill. Oh my God. And then I get a call to my husband and says, Dad just called and said, does he have to sell his house? And I said, don't open the bill. Do you know how scary it is when you go, we just don't send bills? Actually, your seniors want their bills. I want my bill. By the way, I'm a senior now, so I'm excited. I can't wait. I get all those discounts. It's great. It's great. That's kind of funny, but I'm all happy because I went to Medicare. So I moved from my commercial insurance to Medicare, and then I had to decide if I went Medicare Advantage. Being a patient, it's renewal time right now. It's just starting. Being a patient with Medicare Advantage is so much different than being a provider with all the anguish we have with Medicare Advantage. Just so you know, I'm going to give you a little highlights on why so many people are moving. The other thing is you need to remember that I thought the statistics on long COVID was very interesting. Women have it more than men. How interesting. And of course, the deaths. We're still averaging about 350 a day. We all have the ability to have a booster now, right? For me personally, my doctor has to let me know it's okay to take it. We monitor everything we're putting in this body right now to make sure I don't have an adverse reaction. Because you remember, I don't take drugs well, so we're always monitoring, but the rest of you probably have no reason not to get it. We got to keep each other well, because we just can't afford this a second time. Now we're going to hit the fun stuff. How am I doing? Now we're going to hit the fun stuff. I thought this was hysterical. How many of you can see it and hopefully think it's as funny as I did? What does United really stand for? Usually 9 in 10 experience denials. How about Cigna? What does it really stand for? Called in, got no answer. And the blues is mine. You know, all-time favorite, singing the blues. Now, why do we humor? Because the rest of this stuff will not be funny. Just for the record, enjoy this slide, because from here on out, there's a lot of humor. I do free webinars for Compliance 360, and they're all recorded, and they're all no cost. And I started asking this question: who else besides the RACs are giving us anguish? And that last column, whether you can see, it doesn't matter what the percentage is. You see that huge growth? That's Medicare Advantage plans. And I'm going to show you there is massive growth in Medicare Advantage, which I really appreciate the Office of Inspector General starting to audit them, starting to see the abuse. So I want to share some of that with you today. So we're going to cover traditional Medicare first. The RACs are back. I'm sure none of you really knew they didn't, but during the worst of COVID, they weren't auditing. And then Medicare sent out a note that says they've started. I'm going to talk to you a little bit about the prior authorization. Traditional Medicare is doing prior authorization for the first time ever in the last 2 years. They keep thinking that prior authorization is the way to save the Medicare traditional market, that everybody should have to be prior auth, because right now if my doctor wants me to have an MRI of my shoulder, I get it. Done. Traditional Medicare, what prior authorizations? There isn't any. So your doctors could way over order, and they still get paid, and they still get to do it. Medicare Advantage, on the other hand, is like, how do we even get you an MRI? So you have these huge swings between the two different types of Medicare payers. So there's a lot of movement about whether traditional Medicare should go prior auth. Now there's a lot of movement in DC right now about the abuse of prior auth. So we're kind of hoping they're not thinking to expand it into Medicare any more than they already have. How many of you experienced some of the anguish with doing the Botox injections and saying they were medically necessary? Yeah, if you haven't, you probably didn't do any. But if you had, your MAC has a little trouble handling prior authorizations. It took them a full year to figure out how to do them because they're not good at it. Everybody else is. So let's take a look at, by the way, transparency and no surprise bills. You know transparency. This morning, what did I just read? That over 50 to 60% of the hospitals still do nothing. And you kind of think you can't, what do you have to hide? That's what your patients think. By the way, you should ask them. And the fact that payers have to declare now, I'm lickety-split jumping. And I'm going to share with you a real live example that happened 3 days ago with me. And I tried to do something under this No Surprises Act, under the Transparency Act, and trying not to have the out-of-network, and what it took me to try to get answers. And I know what I'm doing. I often wonder, I think I know what I'm doing. So let's talk about the RACs. What are the RACs looking at? Okay, everybody, your hips and knees. You've been a little complacent. You probably haven't been audited like you have been other issues. You will be now. We're having many hips and knees getting audited, 1 midnight stays, and even outpatients. There's 2 sets that have documentation that has to be in your record. Out on my website, which is here how you can get all those things if you'd like them. Out on my website is the class, Inpatient versus OBS, why I love the 2 midnight rule, and hips and knee anguish. You were told in 2017 there's 2 types of screening you have to do to even get to have the knee, and then if you get to be an inpatient. 2 sets. They have to be in your record. We audit these every day. Every day. I get to do a presentation next week to Nebraska. They have 100% audit variance. It's 100. It's not abnormal for me to have 100. So they want to know why the RACs are auditing them. The RACs can only audit the first set. Did you screen according to whether you get to have a new knee or hip? The second, inpatient versus out, the RACs can't audit yet. But it's just a jump and a skip, and you're going to lose your inpatients. So we know how to do this correctly since 2017. If you haven't set up your 2 sets of pre-screening, please get my class. It's so easy, but do it. And if you have a physician's office, the ortho office going, I don't know anything about all that, I just know about the surgery. Well then, pre-op nurse, you better get it. You might have to go back to the general practitioner. But you can't not do it just because the ortho doesn't want to. And I always get a little concerned when you own the orthos. When you employ them, what's the right word you'd like me to use so it doesn't sound offensive? You cut them a check, dudes. And these are the same ones who say to me, we're not doing it and you can't make me. Mississippi turned to the CFO and I said, is that true? Because if it's true, I'm not sure why I'm here. He goes, well, by gosh, they have to do it. Did you tell them? I mean, you're talking to me. Did you tell them we're going to make it easy for them, but they will do it? Did you tell them that? Or you're going to do all your hips and knees for free? And it is frickin' free. It is frickin' free. That is what that says. Because the screening that's required for you to keep your hips and knees, and many of you, that's a bread and butter money. It's just not optional. That's what this one says. This is not optional because it's not frickin' free. CFOs, you would like these. It's not optional because it's not frickin' free. So do it right, and then we don't keep hearing about this and all these audits. It's so hard to listen to this on a national basis, especially when I'm asked, don't the hospitals know this? Well, yeah, we have what I call connectivity issues. The primary care doc is not giving all the information to the ortho doc, who is not giving the information to the OR nurse, who the UR person the UR scheduler, the UR person over surgery should always check to be sure everything is in that record before you ever schedule for surgery. Is that what you're doing? Because they're having a heyday with this. They're just killing us. And the hospitals keep saying we didn't know. Please don't say that. It's fraud. What you want to say is you misunderstood the reg that came out in 2017, and 5 years later you're still not understanding the reg. That's a little hard to swallow, but it's better than we didn't know. Well, you billed anyway. That is the False Claims Act. So we don't want to do that kind of nonsense. We also have, this is something, the only reason I'm sharing this with you because it is so misunderstood. I was at the Alabama HFMA meeting. I was facilitating a transparency work team, which was kind of fun. But this came up, and the CFO said, my patients have to pay more for an outpatient need than they do for an inpatient need. You all know that's not possible, right? Under the APCs from the year 2000, no patient will pay more for an outpatient procedure than the inpatient deductible. For the last 22 years, that has been the rule. How come we don't know that? And Medicare makes it kind of crazy because if you look up their addendum B, you find the CPT code for hips or knees in this example, and it shows that grandma owes $2,024. They can't owe more than the inpatient deductible, which was $1,400. So we in the rev cycle had better be teaching this because I have physicians who say now, somebody must have told them this nonsense slide, told them that their patients pay more for outpatients and he's not making them an outpatient because grandma owes more. Logically, that isn't a correct statement. Just think it through a bit. Would Medicare ever make a patient pay more outpatient than in? Here's what you have to get good at. Number one, when Medicare looked DRG 470, they looked and said, hospitals, why are you whining that we took it off the inpatient-only list? Your outpatient APC payment is so close to your inpatient DRG, why are you whining? It's just like, cash, same thing. The only problem is this. Notice the states they used. The analysis they did, they used the 3 lowest wage states in the country. So wage index, the lowest of the country. So they came up with about 10,000. Then they looked at the APC for the new knee, 10,000. It's a wash. Unfortunately, that's a very, very, very narrow scope. When I did a big survey when this came out, we found the average amount was 15,000. So when you go from an inpatient DRG to an outpatient APC payment, you lose about $5,000 per knee. Critical access hospitals, your payment methodology is different. Have you done your analysis? Because yours is more of a cost report analysis. So you have a hit if you go from in to out. Now, how about the physicians? How many of you know the physician is paid the same for in or out for their needs? They are not paid different based on place of service. So the doc gets paid the same. What about grandma? Does grandma pay different? No. She pays the same, never to exceed the inpatient deductible, let's say $1,400. So the doc gets paid the same, in or out. The patient owes the same, in or out. Who takes the hit? Hospital. So the three parts, hospital, physician, patient, you're the only one that takes a hit. When they keep taking things off the inpatient only list, it means you have to use the 2 midnight rule to support an inpatient surgery or an inpatient. And then you have to realize, okay, what does the charting have to look like? Because we don't have inpatient only now. We have to support why it needs an inpatient. Very different charting. Who's taught your surgeons that? And how many of you love to teach surgeons? Just saying. Mike, you've done a good job, buddy. One of the fun things that we all love teaching surgeons, and not that they're any different than any, but I love it when I teach them because they say things like, we hate the electronic medical record. Everybody heard that? We hate the electronic medical record. After 45 years, you know what I get to say? You hated paper too, move on. You know, I get to say that. You hated the paper, you hate electronic, where did you plan on telling your patient's story at? So we have to make electronic easier for them. By the way, I had a hospital in Mississippi count the clicks the doctor had to put in. He had 42 clicks. And I said, who dreams this nonsense up? Well, the IT department said, you're talking to the wrong group. We needed to sit down with the surgeons to ask them, what are the things we can do to make it easier for you to enter all the information we need in the electronic record? And there is no way you need 42 clicks. Well, we need to track this data and this data. No. Stop. Your doctors hate your electronic records. If you don't know it, you're not listening. Nursing, I have a hospital, the nursing does it all on paper, and then they go into the electronic record and put in what they think people need to know. I thought that was an interesting screening process. But I said to nursing, you're the patient's story. The doctor does it once, you chart 24 hours a day. How do you think your charting isn't going to give me an inpatient? Well, he charted once. And the charting was crappy. UR needs to get in there and help that doctor chart better. But nursing, you are helping me every day of the week why this patient's an inpatient. And when all you chart is they're eating and resting and the family's with them and had a great lunch and able to ambulate without assistance, really, that's an inpatient? Because that's check boxes, just check boxes. You see, we created electronic records and we forgot to talk to the stakeholders. You think you did, now all these years later, I'd suggest you go look again. We're getting killed in audits, killed. We did an audit recently, like I said, I'm getting ready to report on all these, so they're very fresh in my mind. The patient had a 2 midnight stay. Nursing charted patient sleeping. An hour later, patient still sleeping. 3 hours later, patient sleeping. What the f*** are we doing besides watching him sleep? Judas Priest, we chart crappy. And I'm sitting here going, give us that inpatient, United. Like, oh Lord, who wrote that? Nobody taught nursing the power of their charting. You see, we have created a little anguish with payers, and some of it's ours. You know, I always tell hospitals, when you're looking at things coming back as a rejection or denial, figure out what's yours and what's theirs. Because you're going to find some of it's yours. Especially with the critical access hospitals who don't have a lot of their edits put on, please turn them all on. The hospital I'm just dealing with was going to, in Texas, is stripping off their CPT codes because it's failing an edit for drug administration. They're just going to take them off. I went, honey, that's not the way that works. Well, you know, we can get it through if we just take them off. I went, it's because you don't have your edits turned on. The edits are on to keep you from making CPT edits. Errors, you know, like 2 initials when you're not supposed to have 2. They just turn them off. Because payers are not making critical access hospitals, CPT codes are not how you're paid. You're paid rev code and charges. The CPT code is not usually the edit you use to get paid. It is for the big hospitals. So they just took it off. That was a great strategy. And so when we do silly things, then the payers go a little crazy with us, and sometimes we have to fess up. This is Medicare doing the prior authorizations. Stay tuned. Congress believes that the more prior authorizations traditional Medicare has to do, the less abuse we will have with over-ordering. I'm not sure I agree, but you better pay attention. It'll be a big change for us. E&M labeling. You know, for the first time ever this year, many of you employ physicians. For the first time only for your hospital-based docs that you're billing for, and freestanding, but for you specifically, we have a new way we're going to level those visits. And it's supposed to be the Paper Reduction Act, so your doctors don't have to chart so much. They changed the entire process for medical decision making, and they allowed time. For the first time ever, doctors get to get credit for time for level 1 through 5. By itself, time. And then there's 2 ways to get it. The coders you're working with, I can't get a coder to like time. We need to have all these things in the record so we can check. And I said, is there a reason they just can't count face-to-face time? And then all the time after to call the other doctors, and all the time to review the labs at home on their computer, and they get to add it all up in a 24-hour day and say, what level is it now? You don't like that? Well, because we just like the old checky, so we can do it. I think we forgot why the legislation was put in place. Here's a piece you need to pay attention to with payers going wild. We now have more level 4s than we've ever had. 99204 is a new patient, 99214 is an established. You better be prepared. We already have a payer who may be called United or somebody like that, who is, that's funny. I always pick on payers, and the fact is they shouldn't be doing it then, right? Okay, there we go. But they're asking for records because they believe you're upcoding. The bell used to be 1, 2, 3, 4, 5. Now it's 1, 2, 3, 4, 5. 4 is getting paid, and we're having lots more 4s. So what do the payers think? Y'all are upcoding. When in fact, the new methodology allows for more 4s. And so I'm excited for it, but I know you're going to get audited because it's already started. And the perception is you're not following the new guidelines. So you better know the new guidelines, especially if you employ these docs. You are them. So we don't get to say, we don't know that. The other thing I thought was interesting is I set in, how many of you have had the opportunity to sit AHIP, the Association of Health Plans? That is it's free. I sit in on all their training now. They're training their own plans. You can sign up and they'll notify you. I am now trained as though I'm a payer because I need to understand some things. Man, I was so enlightened on their definition of value-based because I'm saying, well, why wouldn't you authorize an MRI? Because they didn't consider it a valued procedure. They needed to have the ultrasound first, or the MRI, or the chest X-ray first, or the X-ray first. And so they're defining value-based care. How many of you think you can? The whole world is value-based payment, not value-based care. Even Humana, who tried it, put out that they couldn't figure out a definition of value-based care. United did by doing value-based care for a new knee. On their webpage, they said, we'll authorize this many PT visits, this many. And that was their definition of value-based care, was to limit the care we got based on their definition of value-based for a new knee. I'm not sure every doctor would agree with that. Are we all widgets? Just kind of interesting. The other thing is that this is also a lot about the prior authorization. I thought this was powerful. If you haven't been following prior authorization, please get yourself signed up. The prior authorization, this was another really interesting one that came from the group that it takes us about 45 minutes to get a prior authorization approved. Not sent in, there's time for all that, but what if it doesn't get approved? Then the real hard work starts. My husband is a perfect example. He was supposed to get an MRI of his shoulder. My husband we were delayed his shoulder because of COVID. When he finally got to go in to get it, it had been another 6 months. My husband's shoulder was hanging, literally hanging. And we had him in a sling so he wasn't in constant pain. The doctor says, I got to have an MRI of this. We've got to see how much damage is there so that we can get this surgery scheduled. So we asked for prior authorization for the surgery, for the MRI. I was told they would approve the MRI, but only to a location 2 hours away. And I said, why aren't you authorizing it to the hospital that's right here? And their comment was, we're going for the best quality for the MRI. Anybody believe that crap? So you know what I said. You're sure, it's just an MRI, dude. An MRI is an MRI is an MRI. So what quality are you talking about? Or are you sure you're not talking price? The freestanding imaging you wanted to send me to, you have a better price with than you do the hospital. CFOs, you better know this is happening. It's called site of service referrals all over the country. The payers are authorizing the care, but to the place they want you to go to, who has the best rates. You all compete with freestanding something. In my town, we just built in my regional area, they just built a brand new freestanding imaging center. So I'm always talking to the hospital CFOs, yo, what's your rate structure for an MRI? Because the freestanding dudes over here are going to take every bit of your business because you're so much higher than they are. And don't talk about quality. And don't say, we have so much higher costs than they do. What patient gives a flip? Do you think my husband cared? Do you think I cared? Because I have to tell you, when I wanted to go to my hospital, and it was my hospital, I want to go there, and they say, well, we'll only cover it if you go to this one 2 hours away. So site of service, I actually experienced it, and I went, you're sending me to the competition. And I said, I want to go here. I want to go. I'm not taking a full day off work to drive 2 hours for him to have his thing and drive back. We all both had to take a full day off work. It's a half-hour procedure in town. I want to go there. Have any of you tried that? Have you told any of your patients to say, I'm not going there? This one is right here. Why am I driving 2 hours? So when I said that to them on the phone, they said, well, we'll prior authorize the MRI of the shoulder. First of all, they wanted x-rays, and I said, over my dead body. That's ridiculous. So, because I'm a high deductible plan, I pay everything. You know that. As high deductibles, we care about all these other things they're ordering instead of the real thing that's needed that the payer will pay. So they told me I could go to the one in town, but they wouldn't pay it because I was not going to the place they wanted it done. They prior authed it, and they told me where to go, and I said, I'm not going there. I want to go to my own town. I was a little shocked, and I said, you won't pay this? And they said, you gotta love it. I wrote all this down, by the way. I can't tell you who the payer is because it's such a horrible if you ask privately. There are no secrets. So I wrote down everything they said, and I said, well, I need to understand this. You tell me it's prior auth, it should pay. This is examples where they say we prior auth, but we don't guarantee payment. Remember, you hear that all the time? This is how it happens. So my husband and I talked about it, and I said, let's just say we're going to go local. We're not going to take a full day off work. Then he said, well, then they told me, why don't you just ask the hospital if you can just pay cash for it, and then you won't have any problem. I said, because I pay a gosh awful amount for insurance every month. You need to pay this. I'd already met our stop loss, so I really wanted it paid. Then I thought, business of healthcare, and I said, well, if you're not going to authorize, if we go to the place you don't want us to go to, and it says he needs to have major reconstructive surgery, it's hanging, remember, major reconstructive surgery, are you going to cover that? And the little nurse on the phone said, if you're not going to go where we send you, we're not going to pay it. It won't be medically necessary, and the surgery will not be either. How many of you think I drove the 2 hours? And I cussed them the whole way. And I said, I will tell your story to the whole country. Because this is wrong. Be the patient. CFOs, you're going to have to fight this with a decent rate. You cannot charge $5,000 for an MRI and the freestanding imaging charges $2,000. You lose every single time. And you don't think the insurance companies aren't directing me to the quality freestanding MRI where they pay that much less? Come on, guys, get your business hats on. We have to be smart. When I say the payers are going wild, they have started site of service. Oklahoma had it first a couple years ago. Now it's everywhere. And I experienced it myself in Twin Falls, Idaho. So it's interesting when you start realizing the stuff you're hearing, just ask your patients, it's happening everywhere. And I can't imagine any of you that have freestanding surgery centers, United came out and said we will not be using a hospital for a surgery unless it's life-threatening. Little carpal tunnels, going freestanding. If they have a freestanding surgery center you compete with, you better get your rates what theirs is. And by the way, there are no secrets anymore. Everybody has to post. So surgery centers don't, but you can find out, right? How can you be that much more than the freestanding surgery and expect me to go to you? I have a high deduct, so I got to go to the cheapest place, and they're going to send me to both. When we talk about this was what I was telling you already about, so we'll skip that slide. What happens if you don't contract with Medicare Advantage plans? This is the best news, and we didn't know it. I don't even take credit for it. One of my physician advisors found this. And it says that if you don't contract with a Medicare Advantage plan, traditional Medicare applies. The 2 midnight rule applies. You don't have to send for prior authorization. You don't get bullied into accepting a rate when you go, wait a minute, I'm not contracted with you, Kaiser. Well, but we need the records. And no. This reg says that traditional Medicare applies. We use the 2 midnight rule. Well, I don't. Well, we do, and the law supports us. Now, if it sounds too good to be true, here's what happens. This was 6 Texas hospitals. They're all critical access. They didn't contract with a single Medicare Advantage plan. They felt that they needed every penny to stay solvent. So they did not. So I shared this class with them, and he said, oh, my land, let me tell you what's really happening. They already knew, because we send a letter. They sent their letter that says this is what the law says. Therefore, we will be using it. Here's our Medicare rate. Remember the cause. Theirs was a per-day rate. They sent it off. They did it every year, and suddenly they started getting these. Every one of the Medicare Advantage plans says, we need you to attach the letter from Medicare that gives us the rates with every claim. So no electronic submission. You have to print them off, attach them. What? Now they just violated the HIPAA standard transactions that covered entities must follow. And you let them do it because you didn't know you had the law on your side. You have the regs on your side. That was the first thing they did. The second thing, and I'm telling you, if you want to know the hospitals this is amazing. There are 6 of them they have a central place trying to battle for them. The second thing they said is even though they sent the letter of how the rate, percentage off bill charges, right, really wasn't too tough, they never got a payment that was right. These Medicare Advantage plans, they had the letter, attached the name, which shouldn't have done, but they did, every single claim, and then the payment wasn't even right. Keeps going. Third thing, when they send this CFO, he was so funny when he's telling me this. They sent the letter from CMS with the letterhead. This one Medicare Advantage plan said, we don't like the format of the letter. I said, have you filed a complaint yet? You do know you have how to file complaints against Medicare Advantage plans. That was an abuse. And then, after all of that, Medicare Advantage plans don't even use cost reports. So, as a critical access hospital, how much of the impact of credit, so you want to be sure, how does the cost report come into play? Because Medicare Advantage plans don't use cost reports with you if you contract with them. And you got to know what you're doing. I always say to critical access hospitals, tell me why you contract with any payer. Well, because they walked in the office and they told us we have to. Yeah, okay, when you're done with that conversation, why do you contract? I was in Iowa, the whole bunch of them don't contract with any payers. I said, why don't you? We're the only one in town. There's 60 miles to the next hospital. Why would I contract? Have you ever thought about that cause, especially you? Where's the next closest hospital? Medicare Advantage plans cannot sell. Where'd that come from? Cannot sell without a provider network. Take your power back. I have a whole class on that. It's called Attacking Medicare Advantage Denials, Take Your Power Back. The biggest thing I'll tell you is right here. First of all, this is abusive. You need to turn these payers in immediately for abuse with this regulation. And the CFO was very dynamic, and he had his whole list ready, and he did file a complaint with CMS. And I have a way for you to do it. It's very easy. We've had it for about 5 years now, that we can file complaints on abuse. You have to work it out. They tried. Remember, they sent the letter, they called, they have all these calls. We put it in the email to the representative for Texas, and they were able to see the abuse. Now we're waiting for the payers to do the right thing, and I think they're going to be fined for doing this. The other thing, big win for you, is this reg. Now, Payers Gone Wild, this reg says now this is for any Medicare Advantage plan. Remember I showed you the graph why we're paying so much attention to Medicare Advantage plans now. This says that if the claim has been prior authorized, you cannot come later and take back payment for not medically necessary. They can't approve a claim and come back 2 years later and hire a company who then says, hey, this one should have been observation instead of inpatient, give us our money back. You cannot do it. And who knew that reg was in there? I have to tell you, here's my change of process that I think you should all do. Rev cycle leaders, this is us. We need to step up on this one. You know how the payers send you a request for records? Don't send the records. You're all terrified of technical denials, right? So you should have a letter from your attorney, your hospital letterhead, to the payer, the request for records for the 3 patients. This is in violation of Chapter 4, Section 10.6. These accounts were approved on this day. Most of them have already been paid on this day. Therefore, you cannot come back later. I'm not doing that. You cannot come back later and take back the money. And I have to tell you, you need to be skippy dancing on this one. Why do I say don't send the records? Because once you send the records, what happens? We move into appeal. If you don't send the records and the attorney letter goes out and says, hey, this is in violation, why do I have it at the attorney's letterhead? Your letterhead with the attorney's signature. I know we work real hard as Rev Cycle Delete leaders. They just don't care it came from us. You know, if your attorney sends it, now people pay attention. But you also tell them in that letter to cease and desist, or you're going to file complaints with CMS, the Papa Bear of all Medicare Advantage plans, and do it. Because these are the only ways we stop this abuse. Now, it's amazing when you start sending these letters, the payer starts doing things that may or may not be interesting to you, but at least you put them on notice and you need to follow through. They don't get to do this, and the reg says so. We have all kinds of examples. Oh my gosh, these are just baby hospitals. This is an 80-bed hospital. They had been approved for this procedure 3 years later, they hired a company, your payers hire companies, and they came back in and said, now this one shouldn't have been approved. 3 years after prior approval and after payment. What do we send? The letter from the, you're in violation. You don't get to do this. And therefore, we put you on notice. We're going to file a complaint, cease and desist. Here's another one. They had 10 one-day stays. This is Connecticut Hospital. From 2018 is where their story was, but they were back to 2016 and 17. They sent 10 record requests. They told them they were all being downgraded from inpatient to OBS and to send back, and they were going to take back money. Send the letter from the attorney immediately. These were approved in 2016 and 17. She gave the dates. These were paid. 2 years later, you're asking for us to do this? No, you're in violation. Keeps going. This is the best one. This is from an Illinois 80-bed hospital. United Healthcare asked for all the records for accounts that had $100 or less as a secondary payer. And you sent them. I go, how about no and heckola no? Now, when she called me, she said, you've got to be kidding. They want records when they're the secondary payer and the balance owing is less than $100. I said, how about just no? Where does it say in your contract you will send unlimited records for no cost? Where does it say that? It doesn't. None of them say that. So I said, here's an idea. We're going to send them a bill. There was 150 records, I think, or is that this class? So we sent them the bill. It was 150 records. We charged them $150 per record. We said, we will consider sending them when you send us our check. And they went, you can't do that. And I said, show me in the contract where it says we have to send you unlimited records, all the record, which is a privacy violation, all of the records at no cost to us. Where does it say that? You have to put your business A game on. Because if you don't know the law, you might get abused. You might get bullied. But the fact of the matter is, know the law. Now, here's another one. We have lots of issues with contracting. So I'm going to hit on a couple topics of contracting. I have 15 minutes, right? You know, I have glasses on. Is that what that really says? How many of you have paper printed off the agenda? I know. It's so obvious my electronic works about as good as the operator. So one of the things that you'll see in contracted, I don't have time to teach it all to you, but I want you to be aware, you have to get your contracts fixed. It's things like this, and again, we talk about operational addendums to contracts. So if you have a contract with a payer, does it talk about why do we have to wait 48 hours before we can ask for an inpatient? Medicare Advantage plans, I got Humana doing that, I got them all over the place. Cigna, Aetna. Where's 48 hours come from? Well, Medicare has a 48-hour rule. Business offices, stop saying that. It's coming from us. Remember years ago when we could only put 48 hours on a bill? Do you know that was never a Medicare reg? The Medicare reg in my class on inpatient versus OBS, the Medicare reg says that we expect a 24-hour average never to exceed 48. What's the 2 midnight rule say? Never more than the second midnight since 2014? You're not going to have 48-hour OBS. But you know what the payers have done? They say, oh, that's like traditional Medicare. In the business office, they come and ask you, I just was in New York, spent a week. They kept asking the business office, well, is that true about the 48? Yeah. I said, please stop saying yes, because you don't really know what they're asking. And you know, the UR is a nurse who's never worked a day in a business office, who counts on us to be the interpreter, and they're just great little nurses who have never worked a day in our field. And so they come in and they ask you, well, the payer said that we can't have inpatient until 48 hours. Well, that's what the law says. We can't put more than 48 hours on a bill. First of all, it was never the law. Second of all, that's been gone since 2014. Even the interpretation is gone. Now, what are the payers doing to us? They're waiting till 48 hours and 1 minute, then you can ask for inpatients. Let me help you with this. I do a ton of UR work. Utilization review, you may call them care managers. Here's what we do a lot of, first touch. When a patient comes into the ER, do you think they're super sick then or 48 hours? Just easy math. Your patients are getting ready to go home. The average length of stay is 4 days. So after 2 days, do you think they're as super sick as they were when they hit the ER? They're already being screened, the lab tests are being ran, we're doing treatment, but we've got to say they're super sick, 48 hours and 1 minute to get an inpatient. Who thinks they're being successful getting inpatients? It's way too late. And you're like, okay, we'll do that. Instead of, no, that isn't Medicare. Remember I put in here a slide for you, we'll get to it, that says Medicare Advantage plans can offer more than traditional, not less. Not less. And I'm going to start auditing. I'm going to start fighting them with that. I haven't done it as well as I should have. So we have a couple more things here. How many of you are having your patients sign this? It's called the appointment of a representative. Absolutely, your Medicare Advantage plans, patients should be signing these. What this says is, De Egusquiza is appointing Dr. Baker to represent me on all issues with United Healthcare. And the patient now has appointed a physician advisor for that hospital in South Carolina. We do it all the time. And now anything that comes up for De Egusquiza in South Carolina, the attending doesn't do it, who doesn't know the first thing about talking to a payer, but a physician advisor who is a trained physician advisor who knows how to talk to payers, who knows all the rules because they're networking with us in the rev cycle, that patient appoints him to battle with them. Some of your payers are, oh, we're only going to talk to the attending. I have to tell you, attendings are really nice doctors who should never talk to a payer. You know what they talk about? How sick the patient is. Well, we all agree the patient was sick, but we want to know why an inpatient. That's the only reason you made the call. Do you know how to do that? You're not going to talk to the attending. You're going to talk to Dr. Baker because I told you to. We have a hospital in Alabama who's been using this for years. And she tracks and trends every payer who says we won't accept it and turns them in to CMS all the time, all the time. And yet they still do it, but that's wrong too. They need to be penalized more. So by using this, your internal physician advisor is using a tool in the Medicare Managed Care Manual that gives us the power to be on behalf of the patient. There is no more, we'll only talk to the attending. We have every single Medicare Advantage patient sign this. It means the registrars need to be taught how to present it. You have to present this form. Hi, I know you have Medicare Advantage, United Healthcare. If there's any problems with your account, it's filled in. Dr. Baker, our internal physician advisor, will talk to the payer on your behalf. No cost, and you can revoke it at any time, but if you would like us to do that on your behalf with your plan, just sign at the bottom. How long did that take? 7 seconds? 10? If you shove it in front of them, you're violating the law. You shouldn't shove any form in front of a patient. And by the way, I'm sick and scared. Could you not give me so many forms to sign, just for the record? Every time I went in the hospital's ER, here's the next set of forms. Here's the next set of forms. I'm like, I think I have a stroke, but so go ahead, give me all those forms to sign. We have to be the patient more. This one really is, be the patient. We are that patient. And they never have to battle with a payer. You who know how to talk to payers, you're doing it on their behalf. What a great way to put your arms around patients. And how many of you think they're going to tell everybody at church, all their neighbors, what a great hospital you are? You're helping them with their insurance problems. Instead of, yeah, they sent me a bill, I guess I owe all this money. You change the whole dialogue when you become that advocate, and this is a big advocate one. All right, traditional Medicare, here's something you must teach. Now, critical access hospitals, you are not DRGs. For the rest of you that are DRGs, you are nurses and your physicians do not understand DRGs. You must teach this. I spend more time with hospitals appealing. Here's an example. The hospital approved the inpatient. The payer said you get 2 days, but you're paid by DRG. Why does it matter how many days you have? Same payment. 2 days, 3 days, 4 days. Do you know that we fight over it and they'll get 2 days approved, and then the UR nurse calls Blue Cross and says, can we have a third day? You don't get the third day. So then we appeal the third day. It's a DRG payment, dudes. You get the same payment whether it's 1, 2, 3, 4. I say that to physicians. I train physician advisors, and they go, well, no, we have to appeal the third day. Why? Who teaches DRGs and how they work in your hospitals? It better be us, because they don't let a coder do it. Bless their sweethearts. They know how to code. They don't have a clue how we get paid. So you teach them. Rev cycles, we are the trainers on this. I should not be still doing physician advisors explaining DRGs 101 to all these docs who are wasting precious manpower fighting for something that doesn't get them a single penny. However, in Pennsylvania, Aetna pulled a little cookie. That's why you look at every downgrade in whether it's a full denial or a partial. Aetna went through and said, this hospital in Pennsylvania had asked for 2 days. They billed for 3, and Aetna came in and took $1,200 off the DRG. Has anybody heard of that? Since when does a DRG have a per day rate? It doesn't. And Aetna didn't have it in their contract. And the poor little hospital goes, now we're going to have to deal with this? How about no? How about heckola no? When that other word you might use. No. Just stop. take your power back. You look at that contract immediately and you say to Aetna, this is in violation, I'm turning you into CMS, this is Medicare Advantage, turning you into CMS is abusive, you don't get to do this. Where does it say in our contract? Be ready to sever the contract. They have to stop. And if you think that's the only Pennsylvania hospital that happened to, we put out a call to HFMA, I did it immediately. Anybody else in Pennsylvania having this trouble? Because we need to get together and force a force of will, which is what HFMA is really powerful for in this state. You know your issues. Last but not least, this is the ugly I'm going to give you because we're running out of time and I want to take some Q&A. How many of you have heard this one? Get these as a denial. Humana, this is directly from a New York account. I just have it. Humana is now the largest Medicare Advantage in the country. How many of you have Humana in your state? No? Do you have United? How about, who's the other ugly? The blue? Blues? UHC and the blues. UHC, gotta love them. So, that's only funny, you know. Unfortunately, United Healthcare uses the same contract nationwide, by the way. That's why the power of addendums are important. I give you a whole list of those in here. This is what Humana did, but United, Aetna, Cigna, they're all doing it. They're stating, remember, they don't use the 2 midnight rule. You send records out. So they're saying if we tell you before discharge that we're not going to give you an inpatient, this is all about inpatients, guys, inpatient, and we tell you to bill OBS, you can bill it as a 131 bill type. But the real problem is, what if it happens after discharge? You send off the records, and Blue Cross takes 7 days to get back to you, 5 days to get back to you. Grandma's gone home. Well, now what do they say? You can't bill anything but 121 bill type. You can't bill anything because you did it after discharge. That is wrong. And you let them get away with it. If they're not going to use the 2 midnight rule, their definition, you send records out, it's taking them 4 to 6 days to get back. Grandma's gone home, and what do you get to bill? Labs and x-rays. Hope you made your good money on that one. 3-day stay, I just saw one, it came across my desk. 3-day stay was Humana, but it doesn't really matter who it is. And the hospital said, I was in North Carolina, they wrote off $2 million for this right here from one payer. But we can't bill anything. Why did you allow that? When we send records out, do you have something in your contract that says they have to have an answer back to you in 24 hours? Do you? I guarantee you don't, because it isn't in there. So, let me get it up here. Here's some examples. Here's Aetna. It took them 6 days to get the answer back. And then in the bottom it says, yeah, you can't do anything but bill 121 bill type. Everybody know what 121 bill type is in the room? It's you won't bill anything but labs and x-rays. It's the free one. 121 is almost free, instead of the 1-3, which has the observation hours and surgeries. So this is a deadly change, and you can't just take it because they can't use it to their advantage. They make you send records. They have no timeline to get them back, and then grandma goes home and they say, too bad, so sad. This one took 6 days to get the answer to the request for inpatient. Aetna. How about United? This one took 4 days. Wait a minute. I want to end with this one because I want to be sure. There's one more I want you to see. Oh, I must have taken it out of this class. Sorry. You realize I teach a lot of classes, and I just updated them all in my foggy brain. And I like to tell people that some of the COVID I still have is foggy brain. I'm going to use that as long as I can. You know, it has nothing to do with age or just dumber and dirt these days, but I'm going to say it's brain fog. So this was the example I wanted you to hear about, because I have a whole section on the class about patient advocacy, but this is a good one for you. This is what I experienced firsthand. I put it in here because when we talk about the payers are the problem, take a look in the mirror, dudes. This was us too. This was my daughter. She's had COVID 3 times. The last time she had cold sores in her mouth, fever blisters, and outside and inside. And she has she's an autoimmune. She's one of the ones that you all need to be vaccinated, because if you get her sick, and she's been sick 3 times, she has no resistance. So we're very sensitive. Now she's having another issue, and I said, we got to get her. She wasn't home, so we took her to a regional hospital. We were going to take her. We weren't sure it'd be considered emergent, so I start calling. And I'll say, let me check to see if this hospital's in your network. So here's what I did. First of all, we went on the web page. Go on the web page. We put in the blues, whatever they were, put in her name, put in her number, and put in the employer. It brought up nobody. I said, nobody. So I had her do it in case it was me. She said, Mama says I don't even have coverage. And I said, well, that can't be possible because we're looking at your card. Then we went to put in, they said, well, you have to put in the name of the organization. So then we did it, then we did it that way. We didn't bring up anything. Then she went to her human resource department. She said, how do I find out who's in my network? Well, you're gonna have to check the webpage. How do I check it? I've been checking it. Human Resources says we have no way of knowing who's in your network. You're gonna have to do that yourself. Keeps going. Number 4, I called the insurance plan. And I said, I need to know who's in the network. So I gave him the name. It took him 4 transferred me 4 times to find somebody who could answer that question. What? I'm calling Idaho for Idaho. You can't tell me if they're in this network. So I called the insurance plan, transferred me 4 times, and I said, here's the name of the hospital that she's going to. It's a region. It's not where she lives. And I need to know if you're in the network. The lady says, well, yes, you are in the network. I said, are you sure? I need to know your name. You know how you do that, right? Oh, gosh, give me your date of birth, your kids' names. I need everything because I don't believe this. No, we can't find it. So then my daughter, in the meantime, has called the insurance plan. They've told her, no, they aren't in network. So guess who I called last? The business office of the hospital. Man, you guys, you got to bail me out. I've now made 4 contacts, and we still don't know if she's in network. How many of you think regular patients are going to do this? Well, they just don't want to know. I wanted to know. I called the business office, and she said, absolutely. What hospital isn't in network in a rural like that environment with a computer? So then I said, what happens now? How many of you think I have doubt we're going to get this claim paid? But when we say to patients, you've got to know your plan and who's in your network, that just happened about 5 days ago. I told my daughter to go ahead and go. You could be treated there, which was what they were trying to do. And I wrote down everybody's name, and I said, let's see what happens. I think to myself, no surprise bills is trying not to go out of network. Do you know why we didn't find it? I did finally ask. Because the insurance plan had the insurance company had sold a plan, and it was under this Miracle Plan name. And I said, Brighter Health. And I said, what employee knows this name? They said, well, they should know it. It's on their card. Now, okay, I'm going to call you a bad name about now. Because everybody said they had this insurance company. But they didn't on the webpage. It was the super secret plan that had been. So instead of putting in like Select Health or Blue Cross, it said Bright Health. And we had no idea that's what it was. How is that meeting our obligation to keep our patients informed? So when you think about payers going wild, this one, it's kind of us too. Last but not least, what if they ask for $1 million medical records? Remember, the law says they do not get to ask for all the records, and if they lose records after you've sent them, you know the HIPAA privacy law says, turn them into the Office of Civil Rights. And it's really fun when you do that. You know, I've sent these records 2 times. I can see they're in the secure portal. Are these your initials? Yes, but we have no records. Now we have a fun conversation. I would do the first time. I wouldn't give them a second chance because that's patients' protected health information. If that's mine and you're losing it, i.e. insurance plan, I'm going to be unhappy with you. And I would expect the hospital to protect me, protect my records. That's what you're there for. Last but not least, the most craziest thing that's happening nationwide are line item audits. You have them in Washington whether you know it or not, because I've been working with some of your hospitals. They call them forensic audits. One of your largest payers in your state, and I have had some conversation about teaching them how we charge in hospitals. They believe that once the room and board, let me get you to that slide, there's 2 main areas they're focusing on, your OR levels. I have a class on how to charge OR. Make sure you get it because it tells you how to say this is what's included in our OR per minute or our OR procedure fee. They're of the opinion that OR $500 a minute covers everything that's done in the OR. Everything. So if you called in an x-ray because you wanted to see if the tube was placed, that's not paid. It gets worser in room and board. That's your new word. Worser. ICU killed me. Pay attention. This payer is coming after your ICUs. I tried really hard to teach them that we don't have a room and board rate that includes ventilators, that includes everything that we could ever do in ICU. So if I'm not on ventilator, I get charged the same as though I am because they want 1 room and board rate for ICU and nothing added to it. I said, oh Lord, a patient in an ICU is so unique. I don't need a ventilator. They denied all ventilators, saying that's part of the ICU rate. You guys, you have your hands full, and you better get really good at documenting what's in your room and board rates, how it's this much direct nursing care, setup of the room for OR, cleanup of the room, staff time. If you haven't done it, you better do it, because I can tell you your payer talked to me. And I am trying really hard to convince this payer they're wrong. And I did not win. And I'm not going to tell you who the payer is. Just get your... I was down in Mississippi. This is where they're getting that nursing covers everything. The Region 8 Mississippi guys, he said, Day, you better tell the country. This is sweeping us. When are you getting audited by the payer? When you have a DRG, not with a straight DRG, critical access says you are a hot potato because you get a percentage of billed charges. When a DRG goes into outlier, they're all getting audited. I mean, I'm looking at some of the big hospitals in the region. I'm sure they meant to take the names off. Big hospitals in the region, and they were wiping out all of your stuff. I looked at a ton of critical accesses. All they left was room and board, that's it. I said, so if I'm in room and board and I'm on oxygen, and they had to come in and do defibrillator, and they had to run an IV and do blood, you mean the charge should be the same for the patient who just got monitored for 20 hours as an inpatient? Yep, we should have one roommate for everything. Are you ready to deal with this? The Southeast has been hit heavily, so they're a little ahead of you, but you better get your A game on, because your payer has taught me, and I'm letting you all know this, because I am still trying. I haven't given up, but I keep fighting. This is, we charge for the cost we had. We charge for ventilator because you had ventilator. We charge for blood because you had blood. There's the base rate, and then we add on that's unique to the patient, right? Y'all better get your, because they're coming after ER. I just got that letter too. They want me to explain how you can charge for laceration repair, and the doctor charges for it too. They think you're overbilling. Get out of my class. There's an ER class that tells you how to defend that. And did you want to see how you fess up to the rest of the country? I thought this was darling. This came from a gentleman in Mississippi, and he said, take a look at the denials. They've been tracking them, and look at your region and see where you are. Average claim denial for larger hospitals. If you look at the Northwest, where are we at? Mountain, that'd be me, 7%. So we're running around a 7% denial from the payers. And do you know what they are? Are they preventable, or are they things that you have to do better? All right, last but not least, this is readmission. Make sure you know the rules on readmission. UR nurses obviously don't. They think it's a 30-day readmission. Rev Michael, it is not a 30-day readmission with traditional Medicare. Stop saying it. If you don't know it, don't say it. Don't shoot from the hip. Just Google the stuff. You just Google it. Ask your phone. It'll tell you. What's Medicare's rule for readmissions? Traditional Medicare's rule is same patient, same day, same symptoms. You don't get two payments. What's a 30-day thing then? It's the 30-day readmission penalty program. They look at the whole year, and they see how well you're doing, and if you had too many readmissions, your next year's payments are hit. It isn't case by case. Who knows this? Zero payments all the time for Medicare Advantage plans. You can do more, not less. You can do more than traditional Medicare, but they're doing much less by not letting you have a same readmitted. We have all kinds of examples of patients with COVID getting readmitted within 17 days and the second one's being denied. Really? Traditional Medicare doesn't do that. Why are you getting to do that? Where does it say in a contract that you signed, and you better not have signed that says 30 days as related, just like traditional Medicare? All right, I am done. And for Q&A, I'll tell you what, I'm going to hang around today. I couldn't catch a flight anyway, so I am here all day. And let me answer questions that way, if that's okay, because I know I went over time. I'm trying really hard not to. But I'm going to just take your questions, and if you want any of these super fun buttons at break, just come grab them. My suitcase is overweight, and I'm on a new airline. So just take these buttons, because I'm figuring out where I'm going to put all my stuff I brought. Thank you so much, everybody, for letting me be with you.